Okay. Ladies and gentlemen, I think we now have our Zoom issue resolved. Can the members online hear us? Hold on one second. I've got to open this computer audio. Can the members online, we have 3 online. Can you hear me?
Yeah. We can hear you, Mr. Chair.
Yeah, thank you. Thank you so much.
Yes.
And if we need to speak, you may have to communicate with us on your chat function there, and I will turn on the computer audio at that time. I'm going to now turn it off. Okay. Almost there. Chairman Setzler, you're not leaving, are you? All right. Okay. Chairman Setzler, let's, well, first of all, sorry, getting in a hurry. I'll call this meeting to order. And we are going to we're going to take up 2 bills today. For anyone that was not clear, we're not taking up 261. We will not be speaking to that bill today. The one that we heard last week, we will be taking up House Bill 290 and also House Bill 605, the camera bill. We're taking up both of those measures. We're going to begin with House Bill 290. Chairman Setzler, there's been a great deal of work that has been done on House Bill 290 since we last met. And I'm going to ask you, everyone I believe has that before them, we're going to ask you to explain the current status of that bill. Thank you, sir.
Thank you, Mr. Chairman, members of the committee. It's a pleasure to come before you again with HB 290. Again, this has been a process that we had looked forward to being very deliberative. One that we took engagement from lots of people. And Mr. Chairman, because of your leadership, that's exactly what it's been. I bring before you today HB 290 committee substitute LC version 338732 ERS. And Mr. Chair, I'd be glad to proceed as you would have me. We've got a bill that at its core is similar to what was presented last time, but there are some important differences. So as it pleases the chair, we'll proceed with going through the bill or questions, or how would you like to proceed, Mr. Chairman?
Chairman Setzler, if you would explain the changes. There's a good number of changes, very positive changes, I believe. If you would go through and explain to the committee all of the changes that have been made over the course of the weekend.
Thank you, Mr. Chairman. I would direct members of the committee to the top of the second page, section 1. This is the Patient Representation and Visitation Act. Because this bill is about patient representation first and visitation second. There's been a lot of discussion about visitors and access to visiting, and that certainly captured attention. That's been on the minds of many, but what this bill is fundamentally about is patient representation. Legal representatives who are representing people in acute care settings or in long-term care settings, having representatives who can act with them or on their behalf if needed. So what we've done, the definition section is similar. I will highlight a couple differences, Mr. Chairman. But the structure of the bill, before we get into this, has 3 sections, and there's really 3 things that it addresses. It addresses patients' legal representatives, which are those legal representatives recognized in state law, further fleshed out here in state law and in federal law, that represent the patient and help them make decisions. And they're core to the decision-making process and the delivery of services. The second part is essential caregivers. Those support persons and caregivers that are defined in federal regulation that we flesh out here. And then the third category of people this addresses is visitors, people that want to go visit people in the hospital or in long-term care settings. So in as much as there's been discussion about visitation, visitation is included down in section 3, but section 1 and section 2 is not about visitors. The core of this bill is about patient representation, and that was that way in the last committee meeting. And the substitute we have here further defines and fleshes that out with great clarity So there should be, again, further clarity in law and further clarity for committee members. In the definition section, the term essential caregiver is very similar to the previous version. What is added is anyone 18 years of old or older who is a support person or caregiver. Support person and caregiver are used in 42 CFR, 42 and 483, the sections relating to hospitals and long-term care settings. So we use those terms in the definition of essential caregiver as further clarification that the essential caregiver is part of delivery of services. They support the patient. They can even, in some cases, administer medicines on a recurring basis as part of the hospital or long-term care provision of care, but they're not the legal representative. But as we walk through the definitions, that's what the first one we see. The second one, the preeminent actor here in this bill is the legal representative. Again, the definition is really almost the same as it was in the last committee hearing, 21 years of old or older, designated by the patient to represent, to exercise such patient's fundamental right. Again, there's a right of patients to have representation. That's fleshed out in federal regulation. In federal regulation, again, 42 CFR 482, dealing with hospitals, says explicitly it is the state's function to do that. And I've got those references cited further down below in the bill. Long-term care facility hasn't changed. That's, again, anything in intensity of care from a skilled nursing facility down to intermediate care through assisted living, community living arrangements, all the way, and also references hospices. That has not changed. One definition, Mr. Chairman, on the top of page 3, visitor was not included before, but for clarification, we have here any individual authorized by a patient or resident to have access to in-person visitation in a hospital or long-term care facility. It's not limited by age. This is anyone that could visit, right? And we will talk about down in the third section of the bill, visitors are going to be regulated by the hospitals and long-term care facilities, as they would. We put no specific regulations on them. It's really up to them to decide how they're regulated, as long as they meet the minimum CMS requirements. Mr. Chairman, we did add this section of 31.7.431, beginning on line 43. Not a fundamental change really, but a clarification that we designate that hospitals and long-term care facilities shall institute policies, and they're distinct policies. It's not a legal representative essential caregiver visitor policy. It is a policy for legal representatives, a policy for essential caregivers, and a policy for visitors, distinct from each other because they are distinct, fundamentally distinct in their roles. And it enumerates that these policies shall be made available to people physically, online, and there's also a process that the facility is designated to set up, which is to provide information and receive complaints relative to these policies. There's just no extra FTEs they're going to hire into their system, just that within their existing processes, there's a point of contact that people can contact or ask questions. And if there are any concerns or complaints about how they would be administered, there's a place to call. It's not just call the hospital somewhere on the campus. It's a specific place, phone number, email, and a physical location. Mr. Chairman, that really kind of sets up these three sections that are core of the bill. Similar to what we had presented in committee last week, we have further fleshed out the definition, the meaning of legal representative. Again, the legal representative is a person that is, as alluded to above, is empowered and designated by the patient, pursuant to the patient's rights. We're not giving representatives rights. We are allowing the representative to serve on behalf of the patient's rights. The patient has a right to have a representative. That's fleshed out currently under Georgia law in a sequence of powers, the patient's first, and then their designated power of attorney, and then their spouse. There's a whole pecking order that's established in current law under 31-9-2. That's referenced here. And what we're providing in this for the legal representative of the patient is in both a hospital or long-term care setting, this legal patient or representative for any hospital stay lasting longer than 12 hours, the patient would have a right to see their legal representative for 1 hour per day minimum. Okay, so that's maintained as it was in the last committee. That's not changed. What we did do at the exhortation of some, as we talk about this, it shall be the policy of the state regarding the patient's exercise of rights. We actually referenced 42 CFR 482.13 B2. That's the section of CMS regulations that states that it is the state's responsibility and power to designate this representative. In fact, I'm reading right out of 42.13 now. The patient or her representative, as allowed under state law, has the right to make informed decisions regarding his or her care. The patient's rights include being informed of his or her health status, being involved in care planning and treatment, being involved to request or refuse treatment. It goes on. So the language you see here under the definition is literally lifted right out of 42 CFR 42.13, and we reference it here. So there's no confusion that in using the term legal representative, we are specifically invoking and answering the question asked under federal regulation where it says, as allowed by the state. We're answering that question, that the legal representative is that person that has those powers to act on behalf of the patient and also consult with the patient, even when they're competent or lucid. There's a person for them to be able to talk with while they're making life-changing decisions for themselves. That's what we do by invoking 42 CFR. Many members of the minority party on the committee asked me about that last time. What's the right way to make those references? So we were careful to try to do that here and to make sure there's no misunderstanding of what we're referencing. The definitions don't really change, Mr. Chairman. We do talk about that it shall be the policy of the state that the patient's rights are part and parcel of having access to this representative. And that the in-person physical contact of a representative is a core part of providing care. It's not a vacation. It's not fun time. It's not recess. It's not a nice to have thing. It is an essential part of the delivery of care. You know, having a representative to make the core decisions about the care someone's going to provide is as essential as the person that wheels in the lunch or that cleans the bedpan or that replaces the IV. Those things are all essential to the delivery of care. We make it very clear here that the representative is as essential as that, and it shall be the policy of the state to protect that. I will tell you one big change, Mr. Chairman, on line 77 through 82 is this question that's been brought to me by many people about what if there's an extraordinary circumstance. And by saying what if, I'm not making light of that. We want to embrace that. We want to embrace this issue of what if there's a really, really extraordinary circumstance, not set of circumstances across the hospital or across the acute care unit, but for a specific patient. You know, what if this patient has a specific circumstance that even having the core decision maker who will make life-changing decisions for them should still be not have physical access. And what we provided, Mr. Chairman, is, and I'll spend a little time on this, that on an individual case-by-case basis, and by the way, Mr. Chairman, for members, this was provided by members, I won't call names, this was provided by members in our acute care community, this core language. We conform that to the language you see here, but the specific elements of this was provided to us by friends in the acute care community that said, for patients in operating rooms, transplant wards, or requiring physical isolation for exceptional immunocompromised conditions, some of the things we talked about in committee as we were talking about as I was taking questions, a patient's attending physician, not the medical director of the hospital or the administrator, but the attending physician may, upon medical necessity, not just being flippant, but upon medical necessity, restrict or postpone a patient's access to in-person physical contact with their designated legal representative for up to 48 hours. That's 2 days. So if there's somebody in the operating room or somebody in a transplant ward or somebody that's is in a really unique downturn in their health conditions, the idea that they might have to wait 24 hours or 12 hours to see their representative, in spite of the fact the representative is a core decision maker in these decisions that are being made, we still give this attending physician a 48-hour delay to keep them out of the hospital from any contact, just out of an abundance of caution, even though decisions might need to be made in 6 hours or 12 hours. This is just that abundance of caution, 2 full days of no access, in spite of their need to make decisions. just out of an abundance of caution to accommodate the concerns of our hospital and our acute care community. And lastly, it just kind of concludes, standing orders of the hospital or the acute care unit shall not satisfy the exception. There can't be a standing policy that says, well, we're under a pandemic circumstance, or we're under a tough time, times are tough, we've got a lot of caseload, no access even to representatives. That can't meet the circumstance. It is a patient-specific, attending physician-specific, based on these critical circumstances, provide as sort of the most sensitive things by members of the acute care community, which give this 48-hour delay, which we think is, we think 1 hour access is very narrow. We think that's not overwhelming, but this was just to address that issue from those in acute care. Mr. Chairman, there's really not significant changes down 84 through 90. Again, hospitals will still have the authority to impose reasonable safety requirements. And they also will post those requirements on the website. And it further says that the reasonable cost of achieving the safety requirements may be borne by the legal representative. It's not the duty of the hospital or long-term care facility to provide PPE or masks. It doesn't say that it shall be. It doesn't prevent them. It says, but they may have the option to put that on the caregiver at their discretion. Top of line, page 5, Mr. Chairman, doesn't change. Once again, the legal representative is the only entity in this bill. It's the only entity in this bill that, in spite of a gubernatorial order or emergency, has the patient has a right to have access to, because they're core to the delivery of services. They're as important as the person that brings in the meals, that changes the IV, that changes the bedpan, that provides nursing care. They're core to the delivery of services because they're the decision maker. And to suggest that the decision maker is not core to delivery of services is being blind to the point of what's really in play. Again, they're not agents of the hospital, and we do have the provision that really hasn't changed, 95 through 100. They may temporarily suspend or terminate if they fail to comply with the safety standards. So even a legal representative who's core to decision making, if they act out, they don't wear their masks, they don't follow procedures, they're obstinate, they're not cooperative, they can be sent out temporarily, or they can be terminated and banished from the acute care facility or the long-term care facility for being uncooperative. We give that discretion to the hospitals and long-term care facilities. And then lastly, this provision that I appreciate the member of the committee brought last time, the idea that a patient who's under custody, if they're a forensic patient, they're being watched by a deputy, they're under arrest, or they're part of a correctional institution, by virtue of being the hospital, they can't designate a representative to come in if they're a prison, a person under custody in prison. The rights of action haven't changed, Mr. Chairman, between lines 100 and 110. What we have in place is the same as the last committee meeting, which is essentially the COVID standard, the same standard that we apply with respect to coronavirus in terms of protecting and providing a little liability protections to hospitals and long-term care facilities pursuant to following these policies. So that's the legal representative section, Mr. Chairman. I know I spent some time with it, but that's a crux of this bill, because this bill really is about patient representation. Mr. Chairman, beginning on line 111 of the substitute essential caregiver, as we alluded to before, the essential caregiver is a person that's part of providing care. They're not the decision maker, but they do help provide care. And this is also fleshed out as a support person under the hospital regulations and otherwise. These are kind of vetted persons who are 18 years of age or older that are part of perhaps sitting with someone overnight if there's concern. They may aspirate, or they may have a drop in their conditions. They help support nursing staff, and even though they're designated by the patient, can be an important support in the system here. Essential caregivers, still subject to gubernatorial order. The governor can prevent them from having access by gubernatorial emergency order. And a lot of folks have criticized me for that. So, well, gosh, why can't the essential caregiver? They're important, and they are important. They're not visitors. But we don't make the essential caregiver, this caregiver person, they still can be managed or controlled by gubernatorial order, because they're part of providing care, but they're not the decision maker. So I wanted to make that clear. And the essential caregiver would have access in a long-term care facility for 2 hours or two people, up to 2 hours a day, a single block of 2 hours. We further clarified that, Mr. Chair. That's a change in the substitute. That's not an hour here and 30 minutes there and another hour here. It's a single 2-hour block. So for management reasons, should the facility desire that, to further clarify, it could be a single 2-hour block of no more than, or up to 2 people. No more than 2 are required. Other than that, Mr. Chairman, we don't change the provisions of essential caregiver much in the substitute. I highlighted those differences, and that tracks all the way down. Again, these are people that if they don't follow the rules, they can get kicked out by the facility. But to be clear, the essential caregiver only has a right to access in a long-term care setting. These essential caregivers, even though they play an important role in hospitals, there's no mandate by this bill for an essential caregiver to be given access by law to the hospital. Only the representative has this legal right we're giving this bill to the hospital. Mr. Chairman, beginning on line 148, this is a new section. This is where we add in and clarify visitors. And we say to members of the committee that hospitals and long-term care facilities shall institute visitor policies. It's the discretion of the hospital or long-term care facility to manage and decide on visitors. We're not telling them how to manage the visitors. All we state is something that's really already provided by law, but I stated here, no more restrictive than the minimum standards promulgated by CMS. So if CMS says you have to give people access in these circumstances, that's all we're requiring for visitors. And that would be, for example, they have these end-of-life care directives that CMS says you have to give people access if someone's about to die. Those things would still apply here. But we don't, in this bill, get into the management of visitors. That's completely at the sole discretion of hospitals and long-term care facilities, because we believe that's because visitation policies, we believe, are really their province. Again, we talk about giving them the power to impose reasonable safety requirements. And that's really what the visitor provision is, but it's to clarify visitors are managed completely by long-term care facilities and are really outside of any prescriptive language in this bill. And that's the request of the facilities. They wanted any number of visitors, family members, 14-year-olds, older folks that are friends, bringing a pound cake to the hospital. All of those are visitors. And those are still purely within the province of hospitals and long-term care facilities to manage. Mr. Chairman, moving on, we're just about done here. Beginning on line 159, the language has been carried over from the previous substitute, the Department of Community Health. They're styled in Title 31 as the department. She'll have the power to write rules and regulations, but narrowly tailored to implement the provisions of this article. And then the department shall also have the power, as we had in the last substitute, to take civil, disciplinary, administrative action as needed to enforce this. So we do give the department powers to flesh these things out. Last two additions, Mr. Chairman, we've added here at the request of many, beginning on line 164. I'll read it for members. Nothing in this article shall be construed to limit any right of a patient recognized under any provision of state or federal law. So this can in no way be construed to limit the rights of patients. Now, right now, we talk about a minimum standard that shall be provided under law, but this in no way says we're taking away patients' rights. We're constricting them or constraining them. We're simply saying that these minimum standards shall be maintained, but if there's any other color of law or regulation that might provide a more expansive recognition of rights, it just clarifies this doesn't change any of that. And then the last provision, this was one that was, again, important to many. The provisions of the article should be construed to comply with the requirements of federal CMS to obtain funding for patients, residents, hospitals, and long-term care facilities. So what this says is we have crafted this to not be in conflict with CMS. In fact, the chair, myself, and one of our other members last week had a 45-minute conference call with the director of compliance for our Department of Community Health. And when we talk to department leadership, they're always in a tough spot because they're trying to be responsive to their chain of command and their leadership, their commissioner and governor and others. But he was, really appreciate their time in the meeting. And we went through every single line of our bill. The previous substitute. And this substitute actually moves in the direction of making compliance even simpler and cleaner. And our bill is not in, is not out of compliance in any provision. Everything in our bill on the legal representative side and on the essential caregiver side both fits within the framework of CMS. I want to say that's very important. What I've heard over the last week or so is sort of a, and I hate to say this, I don't want to get personal, but there's been a whisper campaign in the halls that many of us have heard this, hey, we're going to fall out of compliance. We're going to lose our money. We're going to lose our funding. Setzler's a good guy. He's passionate about this, but this bill, he hasn't done his homework. No, we've done our homework. We've read all of 42, and 4213 and 48310, as well as the state operations manual. And walk through with our regulators. The bill you have before you is compliant with CMS regulations. And as a belt and suspenders, we added this last provision. So nobody can tell us that we're going to somehow, inadvertently fall out of compliance, because we've said these provisions shall be construed to comply. So as there's a need to, if there's questions about compliance in losing funding, these will be construed to comply within the context of that which allows us to continue to receive funding. Okay. It's an uncomfortable conversation with many, because of the whispering we've been hearing. But I want to be crystal clear. This bill is in full compliance, and we've crafted it that way. And we put this belt and suspenders so nobody can look us in the face and say, hey, this on its face doesn't do it. Okay. So I was somewhat hesitant about this because our bill was crafted specifically to be compliant. And we confirmed that even without this clause. But we added it so that there's no color of law where we could be challenged as, yeah, well, you're compliant with the law, but we're going to lose our funding. And you're going to put us in this pickle. Well, that's, Mr. Chairman, should be solved by this last clause of the bill between lines 166 and 168. So with that, Mr. Chairman, I know it's a detailed walk through this. Appreciate the members' indulgence. There are 3 categories in this bill: legal representative, essential caregiver, and then all visitors. And those are clearly distinct, and I'd be glad to take questions.
Thank you, Chairman Setzler, and I do appreciate the great deal of work that we've put into this. We've heard from a multitude of representatives that have been engaged in this, and so many of the changes that have been made are a direct result of that. I do want to mention to our folks online, we are apparently, if you can hear me, we're having some Zoom problems. I apologize for that, but Ms. Tara here is working hard to fix that. All right. We're going to ask questions of Chairman Setzler. I'm going to ask everyone to keep it to one question and be concise. And Chairman, if you will answer concisely as well, please. We've had a lot of debate on this issue. All right. I think we have here, let's see, whose light is that? I'm trying. That's Ms. Robichaud. All right. Representative Robichaud.
Thank you, Chairman. So my one question has to do with line 78 through 82 and understanding the concept around the 48-hour hold per se for patients in operating rooms. But I guess I'm still concerned when we talk about a patient who's in a transplant unit or even is severely or exceptionally immunocompromised. Why do we think that's going to resolve in 48 hours? Appreciate the concept of a legal representative in a hospital. Most people hopefully designate someone as their medical power of attorney. I'm assuming that's what we're pretty much talking about. Mm-hmm. How is that resolved in 48 hours? Or does the doctor reissue the order?
No, I think the issue is this. I trust you all have heard the old colloquialism, no good deed goes unpunished. As soon as you try to recognize some kind of concession, then all of a sudden in this business, you die the death of 10,000 cuts by the way this concession's drawn. Stepping back from this, as we talked about last committee meeting, the massive concession we've already provided in the 4 corners of this bill is that the patient representative, who's the key decision maker, who might be able to provide around the clock surveillance and oversight to a patient around the clock, 12, 14 hours a day, has been constrained already to 1 hour a day. it's my contention, and I certainly believe that 1 hour a day is such a constrained time for the person making the key decisions about a patient. Without this provision, the bill's fine. So if a lack of clarity this provides makes the bill better, I'd be glad for the lady to make an amendment to strike this entire clause of 48 hours, because I think the bill stands on its own with a 1 hour provision. So that would actually be my desire. If this committee, this legislature were to desire to say 1 hour, period, without any clinician override for profound immunocompromised circumstances, that would be my desire. I added this as a sort of a tertiary, sort of a third level of out in the most extreme circumstances. Although I don't think it's necessary. Does it make the bill better? Does it give clinicians and people in these most profoundly compromised circumstances a tool? And I'm hesitant to put it here, but it does give them a tool, and I'm trying to find that balance.
Okay. Chairman Jaspers, is that your light, I believe?
Yes, sir. Number 7.
Numbers.
Thank you. Thank you, Chairman Setzler. You know, of course, I appreciate your passion in this. Absolutely. And I may have missed an earlier meeting and may answer this question, but on line 84.
No confessions required, Mr. Chairman.
Yeah, you know, it's a busy world. But, you know, you talk about hospitals and long-term care facilities should not be prevented from imposing reasonable safety requirements. And as the chairman knows from other bills you and I have worked on and against and for, what I think is reasonable and you think is reasonable can be here or there.
Sure.
So how does a hospital in this particular setting find that line
Yes, sir.
without arguing in the hallway or in the
Sure.
door?
Yeah. We could tighten this language down and take flexibility from our hospitals. You know, we could create a framework that says you shall follow these exact standards, these exact requirements. We can lock it down and take flexibility from them. In bringing this bill, you know, reasonableness is a standard that's applied all the time through law. It may sound to a non-practitioner, maybe it's loose, but it is really the standard on which much hinges in our legal system. And I'm willing to concede that there would be a hospital or a long-term care facility that would impose a set of rules I'm not happy with, that I might personally find unreasonable. But we're still going to give them the power to make that determination. It would require somebody to make a demonstration to the department, or sort of as a last line of defense in a court, if it came to that it's unreasonable. And I believe in these circumstances, I think they're going to get broad berth by courts and by the department. To demonstrate professional unreasonableness is still a pretty high bar. So again, this is one of those issues where people who are advocates for patients would look at the reasonableness and say, gosh, you know, Representative Sesser, you're giving the hospitals and long-term care facilities way too much flexibility to keep people out. I would concede that. Maybe I'm giving them too much flexibility, but reasonableness is a standard that's applied elsewhere in other settings. And I'm willing to let the patient or the legal representative have to demonstrate to the department or demonstrate in court that a first-class hospital system is being unreasonable. That's a high bar to prove. It gives them a lot of flexibility. That's why we've kept it.
Thank you. Thank you, Mr.
Representative Bazemore.
Okay. Thank you, Mr. Chair. Representative Sessler, we have had many robust discussions in several different, over in the Capitol and in this room too, I believe. And after one of them, you and I had a discussion. But first I want to ask you, do you believe with the vaccines that are available that the coronavirus, COVID-19 is on the downtrend? I'm
not qualified to make a clinical determination of that. I can tell you as a state policymaker in a legislative role, it seems that the introduction of vaccines is moving the needle. Okay. I think most would recognize that. I'm monitoring that, as I know you are. I do think it's moving the needle. I hope it stays that way. And I hope, but yes, ma'am.
So I just want to further ask you, since we did have that conversation, and my question to you was, if we did not have COVID-19, would you be introducing this bill? And would you not agree that if this bill goes into effect, into law, it's harder to remove a law than it is to wait and let the science work out and the vaccines work out so that we go back to whatever the hospitals deem necessary and the long-term care facilities deem necessary?
Well, I appreciate your question for two reasons. I'll try to be brief to the chair. Yeah, this bill is written informed by our experiences of the last year. I don't think anybody in this room would have the context and the experience of what could happen in a pandemic setting in particular that we've had by virtue of being elected officials of the last 11 months, going on 12 months now. So this is absolutely informed by the last year of our experience. And I think it helps us write a better bill, helps us understand the circumstances. So yes, it is, and I'm thankful for that. It is mindful specifically of the kinds of circumstances we faced, not just now when even though we still have people who are at risk with COVID-19. Processes have emerged over the last 11 and a half months that facilities have begun to, even without being directed to do so, have begun to ease things up a little bit. But looking back at where we were last March and April, that's what this bill is written for. This bill is written for the next one. It'll be a different circumstance. It may not be a SARS. It may be a different kind of virus. It may not even be a pandemic. It may be some other kind of emergency, heaven forbid. But mindful of the array of circumstances that could exist, what are the essentials that we would want to put in place that we wouldn't want to repeat? It is absolutely the public policy of HB 290 that turning away legal decision makers, legal representatives from hospital settings where they need to be there to make decisions for and alongside of their loved ones is unacceptable in this bill. The idea that members of many of our own families have been turned away. No, yes, I know you're the legal representative. I know this 82-year-old family member who's had a massive heart attack and is in the Guinea Medical Center, as my father-in-law was. Then his daughter, who is his legal representative, was turned away. You may not come in. You may not see him. You may not consult with him. He's completely on his own to make his decisions. That's an unacceptable circumstance. So yeah, this is written specifically because we know this may happen again. And we know there's going to be pressure on the system. There will be uncertainty early in these outbreaks or early in the circumstances. So we've got to provide guidance. What is the minimum level of access that's got to be provided in these key settings? That's exactly why we're doing it, to set a minimum bar.
Okay, we're going to keep moving with these questions. We need to knock these out. Representative Mitchell by Zoom. Representative, can you hear us?
Yes, can you hear me?
Yes, we can hear you.
Great. I am noticing that the new version of this bill has nothing in it about infectious disease and your exceptions. So if we step away from COVID, which we now understand the characteristics of, and we look at other infectious disease, I am concerned that there is no language specifically allowing for exceptions for, say, XDR TB or another disease. Does DPH have a written opinion of this bill, and can that opinion be shared with us?
Well, I think I don't want to speak for others. I will tell you, I think it's generally the decision, I think it's generally the position of the department to say they feel perfectly qualified to manage this themselves. They've managed it for the last year. I don't think I'm stepping out of line to say the department feels like they've been given the sole authority to manage this is something they're up to the task to do. The question is the lawmaking body, should the last year, where it's solely in the hands of the department, vis-a-vis the governor's powers and recommendations from federal agencies, should the circumstances we've seen over the last year be repeated again? And this is no criticism of the department, because there wasn't clarity given to them in law about what this framework was. This issue of legal representative wasn't fleshed out in law that specified the decision maker has to have access a certain amount of time. They were wrestling with this as well. But having had the value of our experience of the last year, we, the lawmaking body, are putting in a minimum framework for them against which they're going to execute this program. So we don't take powers from them to execute within this framework. We just set minimum standards. And with respect to the pandemic circumstance, yeah, we're not the ones to write PPE masking standards. We give the department power to write rules underneath this to flesh this out, and then to be able to make emergency rules as things go. They're the ones that need to do that. We don't need to do that as a legislature. We just need to set minimum standards based on rights and responsibilities under law.
And
Representative
thank
Scott.
you. Sorry,
Okay, thank you, Mr. Chair. Lines 35 through 37, who authorized and empowers outside of the patient? Who has that authority?
No, what we have here is that this is I think a very important reference, Representative Scott. By referencing code section 31-9-2, that's the structure we have in place right now that deals with medical powers of attorney, durable powers of attorney, designated decision makers, pulse form, all the way down to individual, those designated people by law, spouse, and there's a pecking order of family members that is fleshed out. We're not recreating that in this bill. We're just tapping into it. Okay. And what we have here in 35 through 37 is that is the default position with respect to who the representative is, unless in being in the hospital, the patient says, okay, I know my daughter who lives in Kentucky, who's a physician or is an APRN, she's my designated medical representative. But in this case, I need to have my other daughter, who's a school teacher here in Cobb County. She's my representative, okay? Because that's for geographic purposes, for practical reasons. She may be a fully qualified representative. It gives the patient the ability to designate somebody that's appropriate to those circumstances, even if they 2 years earlier or 4 years earlier had set up a medical power of attorney that, should they get incapacitated, would take over. Representative Scott, if someone was presented to the hospital unconscious, they wouldn't have the opportunity to make that designation. It would be that, and again, this hypothetical, the daughter in Kentucky who's an APRN, there would be that, and that couldn't change. But if the patient did have the ability to as they present in the hospital or long-term care facility, to redesignate somebody, they could do that. It gives them the flexibility to do that. They wouldn't be held hostage by something that they had done previously. That's all it does.
Okay. All right. That is all member questions. I know we've asked a lot of questions in previous meetings. I'm going to say this real quick. Is there anyone here otherwise who would like to speak with any organization that I think we know where everybody stands? Is there anyone that would like to say something very briefly? Okay. And again, as I admonished everyone here earlier, Anna, we want it brief, please.
Thank you, Mr. Chairman, members of the committee. I have, again, Anna Adams with the Georgia Hospital Association. On behalf of more than 160 member hospitals in the state of Georgia, we really appreciate Chairman Setzler's willingness to talk with us about this issue. This is incredibly complicated from both a patient representative standpoint, a disease control standpoint, a hospital practices standpoint, and a federal compliance standpoint. We are unfortunately still opposed to this legislation the way that it is currently drafted, and I have shared with you all today a specific list of our concerns. Chairman Setzler referenced in his comments that right now this bill is not out of compliance with CMS guidelines. I'd like to explain that a little bit. Under current CMS guidelines, hospitals are allowed to have visitors in their facility, and they are doing that. But at any given point in time, those guidelines could change. And at that point, we are then stuck with this statute in place and the inability to respond to that. Chairman Setzler in his comments made a remark that I thought was very poignant. The patient representative is the key decision maker, he said. I would like to respectfully disagree with that. The patient is the key decision maker. And we want to make sure that we preserve the patient's right to get to choose who can help them make decisions on their behalf, who can visit on their behalf. And this bill allows the patient representative to choose the essential visitor for the patient without the patient's consent. So that is incredibly concerning. The term unreasonable is used throughout this bill. And I'd also like to point out that unreasonable is something that will be determined by a jury, because this bill creates a private cause of action whereby someone who visits a patient in the hospital who feels that wearing a mask is unreasonable, or who feels that 1 hour per day is unreasonable, the only way to determine whether or not it is reasonable is once they've filed a lawsuit and the jury makes that decision. So these are all things that we are incredibly concerned about. We have offered language to the chair, to the speaker's office, the governor's office, to try to address this important issue. And those languages that we've offered allow for more than 1 hour per day, but they also allow for flexibility. For those of you who are not aware, and this will be my last comment, Mr. Chairman, there is currently an Ebola outbreak in Guinea. That outbreak is getting worse and worse day by day. The United States has issued travel restrictions in order to protect the citizens of the United States, very much in the way that hospitals restrict visitation to protect the patients. They have limited the number of airports that patients can fly in and out of, and Hartsfield-Jackson Atlanta International Airport is one of those airports. So if and when our hospitals begin receiving Ebola patients, I hope that your loved ones are protected. I hope that they are not able to come into contact with those patients. And I hope that you will allow hospitals to continue to make those decisions for the best interest of the patients and the public. So I want to thank you again for working with us on this, and hopefully we will be able to get to a point where we can all agree.
Thank you, Ms. Adams.
Thank you.
All right. In the interest of fairness, we've heard a great deal of individual family testimony. We've gotten those emails. We had many here the first time. Does anyone want to speak from the Nursing Home Association or from the assisted living industry? Just to be fair. I want our hallmark here to be study. We have diligently worked this issue, and we have given everybody absolutely, we have heard everybody's voice. Okay, here's where we are then. All right. Let me just say one thing before we decide what the committee would like to do. I want to first say this, having worked on this issue with all the interested parties, as I just alluded to, and with Chairman Setzler, I want to make sure everybody understands this. There are no bad guys in this discussion. Our hospitals, I said it before, but I'm going to say it again. Our hospitals have been heroes during this pandemic. Our skilled nursing facilities have been heroes. Our assisted living facilities, our home care providers, our community living arrangements, all have been heroes. Moreover, so has our departments, our Department of Community Health and our Department of Public Health. Everyone has been a hero in this pandemic that we still, as was alluded to earlier, suffer with today. This issue today is about policy. The issue we discussed today, and I understand we'll discuss right now, is really about what have we learned having lived through that pandemic, and what do we want to do about it? And that will be up to the will of this body. And so, what is the will of the committee? Representative Kirby.
Thank you, Mr. Chairman. I move to pass.
I have a motion and a second.
By committee substitute, I'm sorry.
Okay. Hold on. Now we're going into discussion. We have a motion. Make sure I've got the right number here. This is the right one. All right, it's LC 388732. I'm sorry, 338732 ERS.
Mr. Chairman.
We have a motion and a second. Mr. Chairman?
Yeah, Mr. Chairman, I do want to say something that just to address the hospitals, one of the hospital's comments, association's comments, excuse me. There is one of the remarks that Ms. Adams made, I would consider a friendly amendment. I wanted to offer the committee at the appropriate time, but you may not be in that posture yet.
A friendly amendment. Okay, we're not in that posture yet, but stand by. Okay, so, all right. Discussion. We have Representative McLeod. Should be on that.
Yes, so I am not in favor of this bill simply because it's still too vague. This is a serious bill. This will affect 10 million people in this, I guess we're near 11 million people in the state. And still the vagueness of reasonable standard, that doesn't work for me. As a chemical engineer and a science major, this cannot work for me. I need specific guidelines. And because the state does not have a mandate on masks, and I do not want it to end up in a situation where the family member and the hospital or the long-term care gets into a battle about who has the authority to do what. If it's not clear, we are going to cause chaos. Thank you.
Thank you, Representative. We have Representative Allen by video remotely. Mr. Representative Allen.
Can you all hear me, Mr. Chairman?
Yes, sir.
Okay, so it's sort of like Representative McLeod. This is a very, very serious issue, and one that we need to be extremely diligent in moving forward on. And I heard Chairman Setzler, and I appreciate all the work that he's done over this, and he has been very willing and listening to some of the feedback that I've given. But I wrote down his quote. He said, "This bill is really about patient representation." And when we started this bill a couple of weeks ago, it was about a response to COVID and people not being able to visit their loved ones or be there. And it seems like, you know, when you take a bill and you try to make it better and it doesn't get better, it just kind of morphs. And I think we've kind of lost sight. And I would just urge that there's more than one way to approach this. I would like to see us stay focused on solving the issue that we started with, which was making sure that a visitor, not all of the layers of different people that can be confusing to a patient and their family, but that a visitor can have access to their loved ones when they are in care. And we've really gotten distracted and morphed away from that into a bill, which I agree that is not as concrete as we'd all like it to be. And it's also put us into a posture of not solving the problem in which it was intended. So I introduced legislation that's very similar. I think we have time. If this is not a bill that is specific to responding to COVID, and it's just a bill on patient representation, I don't see why we would want to rush this, and we would not want to take our time and get it right. So I will not be supporting the bill in committee, but it's only because I think there's more work to be done, and I think we can actually get it right if we slow down, take our time, and listen to everybody. The advocates, the department, the hospitals, the long-term care community, and bring them all to the table and have a robust discussion. So thank you for the time, Mr. Chairman, and thank you, Chairman Setzler, for the work on the bill.
Mr. Chairman, did you want me to? Mr. Chairman, did you want me to address his remarks or just stay out of the committee discussion?
You don't need to address his remarks. Who do we have? Is it McDonald? Representative McDonald? No. Representative Byrd, I'm sorry. The numbers don't line up these days with the way we've changed things. I'm sorry.
It's all right. Thank you very much. I just would like to know how much longer we can wait for loved ones to be able to see their family members. I mean, we've been at this for a year now that people have not been able to see the people they love. They have deteriorated, they have passed. And now I think we need to make the decision to get on with this so that people, even now, I mean, if I'm reading this correctly, this wouldn't even happen until July 1st, right? Is that correct?
That's correct.
So that is now another bunch of months before anyone can see. I realize that there's been some lax and getting a few people in hospitals and facilities now, but this is seriously ridiculous for us not to pass this bill for loved ones to be able to see their loved ones in a facility. Thank you.
Thank you, Representative. Representative Bonner, are you 11? Okay.
Yes.
Representative Bonner.
Hey, thanks, Representative Setzler, for bringing this. I would agree with my colleague, Representative Byrd. It is serious. This is a serious issue, and we have certainly debated it, but I would push back on one thing. It's not complicated. This is not a complicated issue. The mechanics of how it's worked out, I would agree, certainly are going to take some thinking through, possibly some changes in how we do business, but it's not complicated. When we see what's been happening over the last year, And for this to continue, I think when we as policymakers are in a decision or are in a position to alter what's happening now, I think we would be derelict in our duty if we did not move forward with this legislation. So I want to thank you for bringing it, and I look forward to voting yes.
Representative Lahood.
Thank you, Mr. Chairman. And Chairman Sessler, I commend you for all your hard work on the bill. It's a very important issue, and we need to get it right. In my experience, the best outcomes are obtained through the alignment of interest of all parties. And I think everybody that's spoken to this bill, I believe, wants the best thing for best outcome for the patient, the resident, the families, everyone involved. And anything that distracts either party from keeping an aligned interest, I think we need to flush out. On line 162 and 163, it addresses where the department shall be authorized to take civil disciplinary and administrative action against any hospital or long-term care facility for non-compliance with this article. I think that's good. That needs to be there. Like it was pointed out a few minutes ago that there has to be some definition to reasonable, and lines 100 and 101, and also there's identical language on lines 137 and 138, gives the patient or essential caregiver or representative the ability to bring civil action in court, which is where, I guess that's where a jury would define reasonable. You mentioned having a possible amendment a while ago. I'm not sure exactly what you had in mind, but at the appropriate time, I might suggest that we amend the language in the bill and leave the section on line 162 where the department can take appropriate action for noncompliance, but remove lines 100, 101, and 137 and 138.
Okay, Representative Lahood, here's what we'll do. We're going to continue with discussion. And then if you are interested in making an amendment, I would like you to go ahead and write it out and have it concrete. And we will come back and we'll address any and all amendments by any members after we're finished with the discussion. So please do so as you see fit. We're going to go right now to Representative Nguyen by Zoom.
Thank you, Mr. Chair. I still have concerns about just the inability of hospitals and facilities to make exceptions in cases where we do have infectious disease outbreaks, such as Ebola. And then, I am very concerned that we don't have the support of the hospitals here, especially given they are the ones who have seen everything on the front lines as it pertains to this pandemic. And so I know that there's been conversation about some language in another bill that seemed like everybody was able to support. So I just, want to think about whether or not we have opportunities. And I know that this is the third time we've heard this bill in committee. But to me, if there is something out there that everybody agrees upon, it seems prudent to think about that as well. Thank you, Mr. Chair.
Thank you, Representative Nguyen. Representative Jaspers.
Thank you, Mr. Chairman. As I listened to Representative Byrd and Bonner, just made a couple of notes thinking about this. Bills always need work. And Chairman Setzer, you've threaded a needle that I think is very difficult. And you're a detailed man, and I reject anyone saying that your work here is not clear. It's very clear. And you've done a very good job with that. And I've had some of my attorneys, I may have misled some folks a minute ago when I talked about reasonableness. I've had quite an education by text that reasonability is the standard in law. And I thank you, those in the audience and out in the people who are watching this. And that I take that back. Thank you.
Sure. Sure.
Thank you, Chairman Jaspers. Is it Representative Benton? I've got 23s flashing. Who's 23? Oh, is that not McDonald? Okay, I think sometimes they just flash for no reason. I apologize. Sorry about that. Representative McDonald, I know you're flashing. Okay.
Mr. Chairman, just point of clarification on line, 98, to any patient or resident who's under the custody of law enforcement agency or correctional institution. I had a question as to, in an institution like, say, we use Grady or other regional hospitals that may have a mental health floor that's a designated floor. How does this affect that? I was trying to find something in there that you don't have law enforcement there or a correctional officer there, how, as far as visiting in there to protect the patient and the visitor. Just wanted some clarification on that.
Sure, sure. Again, this is intended to avoid an unintended consequence of, by virtue of somebody that's been arrested, that's being watched by a deputy, being in a hospital setting, but by virtue of them being in a hospital setting, not in jail, this bill does not give rise to them being able to call and have a special representative come represent them, or if they're in prison, hey, I get this extra representative that gets to come see me simply by virtue of this. So we're trying to avoid that unintended consequence. There are a number of settings where the way patients that are not super compliant are managed, which is why we're further not trying to solve every single circumstance unless unless it's an always circumstance. The always circumstance we address here is the hospital always has, or long-term care facility always has the power to say, you misbehave, you're not following our rules, you're out. And there's always the circumstance, just because if they're a prisoner in confinement, they don't have a right to say, well, now that I'm in the hospital, now it gives rise to this new right for me. But the specifics of, and I'm not trying to sidestep your question, the specifics of a person that's a patient that, you could have a drug addict that's going through withdrawals and is in a circumstance that's not pretty, for a representative to come. I think one thing people miss is, this isn't some duty for this representative to come and have close contact. It's simply an opportunity for that to happen should there be a need for that. So if you've got a patient that's acting out in a response to coming down off of a drug, or somebody that's violent because of some behavioral issue, this doesn't in no way requires a representative to go get some distance from him. It simply says this patient has a right to have this person arrive, and as the representative to be able to make a judgment call, to be there, to be present, not to be looking at them through a Zoom experience, but to be present in the facility and make a reasoned call. How close do I want to be with this person so I can evaluate where they are and make decisions about care? That's all we're doing with this.
Thank
you. Yeah.
Representative McLeod.
Let me make this clear. This is not just an issue of law. This is an issue of health and science and data.
It is.
Thank you.
Part of it. Yeah. Thank you.
All right. I don't, online.
Mr. Chairman.
Okay. Representative Wynn is heard. All right. Okay. Chairman, anything you'd like to add?
Yes, sir, Mr. Chairman.
All right, we're now at the point. All right, so we thoroughly discussed this. Now is the time for any proposed amendments. We're going to logically begin with the chairman and the sponsor of the bill, who apparently has an amendment. Please explain.
It'll be a simple one, Mr. Chairman. Look on page 2, line 27. Part of this, we're writing bills at 3 or 4 layers. We're writing bills to be clear, to be solid within Georgia law, to tie into federal regulations, to be clear to the reader. One thing that was alluded to by the Hospital Association, Ms. Adams referenced, we're giving this essential, we're giving the legal representative the power to decide essential caregivers. what I'm going to propose to clarify that was a clarification that if the patient themselves are not able to consent, or they're not in a position to designate, the legal representative would naturally be the one to make those decisions. So we listed it here. I think, Mr. Chairman, to avoid any confusion about what that means, if we were to strike on line 27 the word or legal representative, strike that, I'm sorry, between patient and resident, and put in the word or, and then strike the word legal representative, what that would do is it would address that issue so that it would be the patient or the resident's authority and power to designate their essential caregivers. And then if the legal representative was operating pursuant to their authority as the representative, they could designate the person anyway. So we strike this out. If the circumstance arose where you had a patient that was incapacitated, the representative could still make that determination, even if it's stricken. But it does clarify the issue raised by Ms. Adams. So if we strike legal representative there and just put patient or resident, it should clarify that. And that, I mean, if a member would offer that, I would see that as a friendly amendment, Mr. Chairman.
All right, while our members contemplate that, we're going to go to Representative Lahood for an amendment. And I want everyone heard the chairman real clearly. I'll come back to that. Let's first hear what Representative Lahood has to say. Representative?
Thank you.
You may catch that at the same time.
Yep. I propose that I propose an amendment to strike lines 100 through 102 and lines 137 through 139.
All right. And Ms. Betsy, as we have, let me say something first of all, Ms. Howerton, we have debated this bill back and forth. Has been a champion rewriting this measure a myriad of times, but thank you. And now we depend on you yet again, Betsy. So we'll let Betsy get this down.
Mr. Chairman, can I address the?
Not yet, sir. Let's, I don't know that I've heard the whole amendment yet, the recommendation.
And
What is the motion?
I want to add one more suggestion to the amendment. In the title of the act, you've got Patient Representation and Visitation Act. I've heard from some of the long-term care community, and to accurately represent the entire spectrum, some of the residential long-term care providers would like to see the word resident used in the title, just to accurately describe the entire spectrum of provider groups that we're covering.
So what, Representative, what is the amendment?
To add, after patient, add and resident representation and visitation act.
Okay, I just want to make sure that Ms. Howerton is hearing this clearly. Betsy, did you get the previous amendment as well?
Mr. Chairman.
One amendment? Hold on. Huh?
But
I can't hear you. Go ahead.
Mr. Chairman, before we
Got to sit a second on this.
before he places that in the form of an amendment, could I ask a question of the author, by chance?
Go ahead, sir. Mhm.
Thank you, Mr. Chairman. In 100 through 102 and then 137 to 139, it is the patient's right to bring civil action. I think getting back to this issue of patient or legal representative, giving standing for the representatives themselves of their own volition to bring action is an expansion of what would naturally be a right. My question to the author would be, if we were to strike or legal representative on line 100 and or essential caregiver on line 137, to clarify that the patient may bring civil action, which I think they have today under law, but to clarify it here, eliminating this outside party having power to do that, does that satisfy the gentleman's concern?
Okay, Representative Lahood, we're discussing your almost amendment. Go ahead.
Well, I'm not a lawyer, and I don't apologize for that, but I'm just stating the fact that I'm not I'm not sure. I would imagine that a patient does have the right to bring civil action. So I'm okay with just striking the or legal representative on line 100. So I'm modifying my amendment. And
It's
on
not
line one-
officially an amendment yet.
Yep.
I don't think.
I'm
never
modifying
got a
my
second.
proposed amendment, and on line 137, strike or essential caregiver.
Okay, all right. So Ms. Howerton, are we clear?
Yeah.
Okay, Betsy's keeping up with this. So Betsy, if you could explain, first of all, do we have a second to Representative Lahood's amendment? Okay. Betsy, will you read back precisely what the Lahood amendment will change so that we're all very clear? Okay, Betsy.
Okay. The first change would be on line 18 to add the words "and resident" after patient. So it would be the Patient and Resident Representation and Visitation Act. The next change would be on line 100 to delete the words "or legal representative." And then the third change would be on line 137 to delete the words "or essential caregiver."
Yeah, we're gonna get Ed's. We're gonna come back to Ed's. No, he didn't get Ed's. I thought we'd get it at one time. We didn't. We'll come back to that. Okay.
Oh, I'm sorry.
All right, everybody. Let me turn these off. Thank you, Ms. Howerton. All right, we have the Lahood Amendment. Any discussion about the Lahood Amendment now that it's been offered and we know precisely what it says? Okay, there being none, we'll all now vote on the Lahood Amendment. All those in favor, say aye. All those opposed?
No.
Sorry. If those via Zoom, if you could vote again, we want to make sure we hear you.
I'm in.
The ayes clearly have it. Does everybody accept that? Is there anybody opposed to accepting that? Okay, so the Lahood Amendment passes. All right. Now, since we didn't capture it there, Chairman Setzler, you explained your desire earlier. Is there another amendment? Is there anyone who would like to? Representative Gamble, what
Yes.
number are you? All right, Representative Gamble.
Thank you, Mr. Chairman. I'd like to amend line 27 to insert between patient and resident the word "or," and to strike after the word "resident" "or legal representative."
Okay, we got our second, okay? We have an amendment offered and a second. We'll let Betsy read it back to us to be clear, then we'll vote on the Gamble amendment. Let me turn you on, Betsy, what number again? 5, I think
5.
you said? Okay.
So that would be on line 27 to replace the phrase "patient, resident, or legal representative" with "patient or resident."
All right, everyone has heard the Gamble amendment. Any conversation? Any discussion? All right, all in favor of the Gamble amendment that was just described, vote yes.
Yes.
All opposed? Okay. All right. Sounds like that is unanimous. I'm having to continue to turn this on and off here. All right. So we do have another amendment that is being offered by Representative Cannon. Representative Cannon, hold on. I'm going to turn on the computer audio. We recognize Representative Cannon for an amendment.
Thank you. I'd like to make an amendment striking lines 91 and 92, as well as striking lines 111 through 117. My concern here is that we are removing powers from the governor, and we have not yet heard about the governor's input on this, nor the impact it can have in future pandemics.
Thank you, Representative Cannon. Do we have a second to Representative Cannon's amendment? Okay,
I'll
we have a
second, Mr. Chair.
Second.
Okay, we have a second. All right, any discussion on the Cannon amendment? All right, I got ahead of myself. Betsy, if we will get Betsy again in the interest of keeping this consistent. Ms. Howerton will read us the Cannon amendment.
And then on, let's see, we would strike, I think what she was talking about was 112 through 117. And again, we would need to re-letter.
Mr. Okay. Is it, everyone should be aware, clear now on the Cannon amendment?
Mr. Chairman?
Yeah,
Could I?
yes.
Can I address that briefly, Mr. Chairman?
I got you on. Okay, yeah. Chairman Setzler, yes, you can address that amendment.
I appreciate Representative Cannon's candor. I would say it's not atypical for an agency to oppose any legislative impositions on their authorities, should we say? But I think that would really undermine the efficacy of this bill. So respectfully, Mr. Chairman, I would be opposed to the amendment, but I just glad to take questions.
Thank you, Chairman. We understand. All right. Okay, now, so on the Cannon amendment, all in favor, vote aye.
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 Okay, all opposed, no? No. Okay, it appears the noes have it. The Cannon amendment has been defeated. Are there any other amendments offered by members of this committee? There is. Representative Mitchell, you're recognized.
Thank you. I would like to propose an amendment on line 79 that we add requiring physical isolation for exceptional infectious disease conditions other than SARS-CoV-2 to allow hospitals time to actually prepare to deal with those patients and the visitors safely.
Okay, thank you, Representative. I want to make sure that Ms. Howerton heard you well. Sometimes it's difficult to hear on the audio. Okay, Ms. Howerton did not get that. So can you text that in the chat, Representative Mitchell, to be clear? Or we're certainly glad for you to state it again, but it might really be helpful to text it in the chat box here.
Okay, I texted it. It's line 79, so just adding a comma and then physical isolation for exceptional infectious disease conditions.
Did you hear that, Ms. Howerton? Physical isolation for infection disease conditions. Okay, thank you, Representative Mitchell. Okay, we have now the Mitchell Amendment. Okay, and Betsy, oh, do we have a second?
Second.
Okay, we have a second. Ms. Howerton, would you read us the Mitchell Amendment?
exceptional infectious disease. Oh, and in immunocompromised conditions.
Yeah, I think that's right, Ms. Howard. I think would be inclusive of the immunocompromised conditions. And she's
I
added this new.
can't actually hear her. Is it possible to turn on her microphone?
I'm sorry, Ms. Mitchell, I couldn't hear you.
Dr. Mitchell, but I can't hear Betsy either. Could her microphone be enabled?
I can't.
I think so. Specifically excluding SARS.
Stand by, Representative Mitchell. We're gonna read it again. Betsy's working with Tara to make sure we've got it precise.
Conditions. Okay, gotcha. Yeah, yep. Infectious disease.
Ms. Howerton, if you would read it one more time.
Okay.
Representative Mitchell couldn't hear you. If you would read
Okay.
that one more
So-
time, the Mitchell Amendment.
All right, on line 79, replace the language exceptional immunocompromised conditions with exceptional, now I can't read my writing, infectious disease conditions.
Is that correct, Representative Mitchell?
No, actually, we would need both, right? So you'd need requiring physical isolation for exceptional immunocompromised conditions or requiring physical isolation for exceptional infectious disease conditions other than infection with SARS-CoV-2, which is the causative agent of COVID.
Okay.
Okay,
All right, we're getting there.
we're getting there. All right.
Could you repeat the part about the SARS at the end, please? Other
So
than-
I'm specifically excluding the causative agent of COVID-19. So saying that this would give the hospitals the 48 hours to prepare for any other, for allowing visitation for any patient who has a different infectious disease, like Ebola, like XDR-TB, so that we give hospitals time to be prepared to allow that visitation.
Stand by, we're working on it.
While Ms. Howardon's addressing that, could I speak to that, Mr.
Yeah,
Chairman?
yeah, Chairman, in the interest of time, while we're getting it right, would you like to comment to that amendment?
Appreciate the lady's question. I think the concern I would share with that is, this would be a circumstance that would limit someone if they contracted COVID and they went into a hospital facility. This would prevent you from having access as contemplated. So if the patient themselves had COVID-19, you could be prevented because of them having COVID-19 from being able to see your family member for conceivably 72, the 24-hour base, an extension to 48, it could be a 72-hour period. And that's not in the spirit of the bill. I mean, I appreciate it's a policy question for members, but I would oppose the amendment.
May I respond to that?
No, ma'am. Hold on one second. We are in the posture of getting the amendment. All right, Ms. Howerton, please read the Mitchell Amendment. You're on.
Okay, so I believe on line 79, after the word conditions, comma, we're going to add or requiring physical isolation for infectious disease conditions, specifically excluding SARS-CoV-2.
Correct. So that specifically
Okay.
excludes COVID patients.
Is that correct, Ms. Mitchell?
That is correct. I'm still not a miss.
Okay, Representative Mitchell. All right. Has everyone heard? We have a second to the Mitchell Amendment. Now you've heard Betsy read it. It appears that the representative who has made the amendment agrees. Those in favor will vote aye.
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 Those opposed vote no. Appears the noes have it and the Mitchell Amendment has been defeated. All right. Anything else on? All right. Okay. All right. That's you, isn't it? I think this is. Okay. Chairman, Representative Kirby.
Thank you, Mr. Chairman. So the only thing we've got left now is the motion do pass as amended for this LC. But I did want to address Representative Mitchell's motion, even though it did fail. Actually, I think I understand when she made the comment, giving hospitals time to prepare, that's not what that section of this bill says. This is about having the patient needing 48 hours staying away from people, not the hospital. And now that may be something that she might want to address if we move this on and cross the hall or something else before it comes back on, should a hospital have some time for these other things like an Ebola? Though I've got a lot of confidence in our hospitals around the state that did a good job last time we had Ebola and doing this without us telling them to. So with all that said, I'm going to ask for the question.
Okay.
Mr. Chair.
All right. I got her off. Okay. Chairman?
Mr. Chairman, I spoke to our hospital association representatives here. There is when we made the amendment that Representative Hood made with respect to the line 100-101, there is an area that I think we mirrored the language in section 431 and 432. I think on lines 95 and 101, there is a reference to hospital may temporarily suspend and the hospital, failure of the hospital. In 31.7, 432 of the code, this, wait a minute. I'm in the wrong section. Nope, I am in the wrong section. Forgive me for that, Mr. Chairman. I may rescind what I'm saying. This is wrong line number. Forgive me for that. I'm on line, look instead on line 132 and 138. On line 132 or 138, it references a hospital or long-term care facility. As you recall, there's no duty for the hospitals to provide access under this bill to provide access to essential caregivers. So Mr. Chairman, as a clarification, it doesn't, I don't believe it hurts specifically, but I think as a clarification, I think I would certainly see it as a friendly amendment. I don't think it's needed, but I think for cleanup on line 132 and 138, the reference to hospital or, and by removing hospital or and hospital from 132 and 138 respectively, hospitals don't have any duty to provide access to long-term, to essential caregivers here. So if they were stricken from this, it would clarify that the only duty is for long-term care facilities in this bill to provide access. So if that were an amendment, I think the hospital folks would be friendly to that. And I would, if you remove hospital from hospital or in 132 and hospital on 138, accordingly, that would remove any question there. And that would be a cleanup effort if it pleased the committee.
Okay. All right. Since we're still in the posture of offering amendments, the chair will offer an amendment. On line 32, we will strike hospital or.
132.
132, is that correct?
132, yes, sir.
Yes, hospital or. On line 138, we will strike hospital, comma, I'm sorry. And I think that captures everything you just spoke to. I was distracted a little bit. All right, Ms. Howerton. First of all, do we have a second to that amendment? We have a second. Now we have a Petri Amendment. Okay, Ms. Howerton, will you read that back and then we'll answer any questions?
Okay, on line 132, strike hospital or, and on line 138, replace hospital, comma, long-term care facility, comma, or governmental entity with long-term care facility or governmental entity.
Thank you, Ms. Howerton. Okay, we have some questions, discussion related to this amendment. Ms. Representative McLeod.
No, I was actually wanting to offer an amendment.
Oh, I'm so, okay. Well, I will come back to you. Representative Robichaud.
So just for, if we're doing a cleanup, wouldn't you agree on line 140, 141, and 143? Also, you have the hospital. I mean, if this is about caregiver access versus representative access, shouldn't that also?
Yeah.
For
What
cleanup?
I would say this, I would prefer to leave hospital there because this, if you hear me out, why, this provides legal protection to the hospital. If they choose to provide access to a central caregiver in these circumstances, I'm friendly to them having legal protections in that way. This is the issues above is duties we're imposing on them. And I think I want to put the hospitals in a posture not required by this bill, but to be friendly to receiving essential caregivers in hospital settings as 42 CFR contemplates. I would prefer to leave the protection there to take out these other two provisions.
Okay, any other discussion on what is now the Petri Amendment? Representative Byrd.
So I just want to be clear. So by taking out the word hospital, does this mean that they will not have the ability to give you the 1 hour to come into the hospital to visit?
No, ma'am. This is only in the code section that refers to essential caregivers, not the representative. The representative still has the right by law to come in. The essential caregivers, this bill gives essential caregivers right by access to go to the long-term care settings. But there's no, this bill doesn't provide any duty to hospitals to let these essential caregivers come in, sort of category 2. It's only the legal representatives have access to the hospital in this, which is why the hospital is not needed on 132 and 138.
Okay.
Okay.
So again,
any further discussion? Okay. Everybody's heard the Petri Amendment. We've had discussion. All in favor? Say aye. All opposed?
Aye.
Okay. No opposed. Thank you. Okay. I believe we have one more amendment. Okay. And that is Representative McLeod. Okay. You're recognized, Representative McLeod, for an amendment.
Thank you, Chairman. So I'm wondering if we could look at the a substitute from either Representative Eric Allen or Representative Bonnie Rich on this particular law.
Okay, Chairman, the chairman was going to ask you a question. Is that an amendment? We need an amendment to this substitute that is before us. So we have a motion and a second on LC 338732 ERS. It has now been amended 3 times. So do you have an amendment offered on this measure?
No, I don't think this bill
Okay,
is just
thank
solved.
you. Thank you, Representative. All right. If there are no further amendments, see none. I think we've got a call for the question. All right. So we're dealing with the substitute to House Bill 290 as amended. All in favor, vote aye. All opposed?
No.
Okay, let's do it this way. Let's just be clear. Let's get a show of hands. All in favor, and online, we'll try to capture that as well. You can just wave to us on your type us a wave. All in favor, raise your right hand. Okay. All opposed? And online, just make sure you bear with us one moment. Okay, we've got you. The measure passes. And so, Chairman Sessler, this bill is passed.
Chairman, thank you.
And just get with us later to fill out the necessary paperwork
Appreciate
going
it.
forward.
Thanks, time and resources.
All right. Thank you, Chairman Sessler. All right. We will now turn to Chair Lady Cooper's bill, which I'm looking for. We have a new sub.
We do have a sub. It's LC 338718S.
Thank you, Chair Lady Cooper. We're working here to make sure everybody has a copy. I know you made some changes that you want to explain to the committee, and
Right.
we want to make sure everybody has a copy of that new version.
Okay. We're doing that.
Okay, if all members have
Yeah.
the new substitute to House Bill 605, I want to make sure that everybody has LC 338718S. That was just passed out by Ms. Tara. And Chair Lady Cooper, we will let you explain the measure and particularly any changes you made from our last meeting. Thank you.
Thank you, Mr. Chairman. For members that weren't here last time, as I started out, I said that the pandemic has made it even more important for Georgia families to be able to see their loved ones that are in either long-term health care facilities or in assisted living facilities. So they are reassured by their safety. And I know that families are anxious about their loved ones. And so this bill is to ensure that families have transparent and open access to install video cameras in residence rooms in order to check on their family members. And the bill really does three things. It protects patients' privacy rights. Number two, it facilitates safe, quality care for vulnerable seniors. When you have transparency and cameras are out in the open, people know that they're being watched. And it is human nature that when you are being watched, that you take extra care with what you're doing. And third but not least, it puts and makes sure that we do not put an unduly burden on our elder care facilities. I think anybody on this committee knows, and in this chamber, that I am a patient care advocate. I have passed numerous bills tightening our rules about elder abuse, and certainly do not want to do anything but promote patient safety in these facilities. And I have certainly taken on the nursing home. And last year, you know, I took on the assisted living facilities for what I considered substandard care. And with no holds barred on how I have responded to them. But we do need these facilities. There are seniors across our state that cannot live independently, who want to live in assisted living facilities. And there are seniors that are even more vulnerable that have nowhere else to go except nursing homes. And so we cannot put undue burdens on these facilities. We have to have them. So what we need to do is we use this, and the new law is work together. What we've done and the changes since last meeting, and I appreciate we were late last meeting, and I appreciate y'all all sticking around for this one. We've made a few language changes to include the possibility of more than one roommate in a room, and changing the term representative to designated agent. We have also acknowledged that facilities may choose to provide Wi-Fi, and when they do so, they can charge the resident a reasonable fee for that service. Thanks for the clarification on the last meeting that reasonable is something that we use in our laws. I mean, I can see how that would be a great selling facility for an assisted facility living home, to say that we're already ready there. We have cameras in the room. You're connect up. Your family members can see you, anytime they want to. One of the things that we did, and we worked and discussed quite at length with the state ombudsman, and I have worked with Melanie McNeil for years. Our state ombudsman is great and has, the welfare of our seniors foremost in her mind. But I will tell you that this time we had a little bit of a disagreement. And the chairman and I have come to decide, I had really prepared two bills for you, one way and one the other. And we have chosen to go this route because we feel like it's more protection of patient privacy. The state ombudsman wanted us to put on the form that patients will fill out just two boxes, basically. You know, you allow videos to run, you know, or you don't allow them. There was no check boxes to say, I want the camera turned off when I'm having a bath and having personal care, or I want the camera turned off when I'm having an exam by a physician, or I want the camera turned off when my husband comes, basically, and we would like to have a little whoopee, as used to be said in the days gone by. And we just felt like that we had to give that option. I mean,
Who said
now-
we didn't have an exciting committee?
Right. It makes quite a visual. It makes quite a visual for you, but I did hear that there was a gentleman in one of the homes that had a regular Wednesday, appointment with a visitor that came. So, where there's life, there's a way. So here we go. We might as well have a good time at 6 o'clock at night. So we did put on the form those exceptions. Now I can tell you for the nursing homes and these facilities, it would have been much easier to go with the ombudsman's version. You turn it on and that's the way it's supposed to stay on. And of course, what Melanie, our ombudsman, said is that patients could then make the decision. But unfortunately, probably about 60% or more of the people, either in a nursing home, even higher in the nursing home than 60%, or in an assisted living facility, they have impaired cognitive ability. Are they going to remember or be able to say, I don't turn it off when I get a bath or something personal care, or, you're treating my decubitus ulcer and I'm going to perhaps be really exposed? What about their roommates? So we decided, if the committee agrees, to go with the one that did list these exceptions, these 4 exceptions to them. We also made some changes to the consent form around the roommate. One of the things about it is that in nursing homes, most of the time, there are 2 people to a room, or often there's 2 people to the room. And the other patient has privacy rights. I mean, do they want the camera turned off at certain times? We need to realize that it's not just the person who wants or the family that wants the camera on their family member, but if they're sharing a room, that other person has privacy rights also. And so, we, added a block and then some information in the bill about that. For example, the other roommate may be fine with having the camera on and the volume and the audio on, but may not want the film in that camera to be used like in a television ad. Now, I can't imagine why you would do that, but are shared with a certain place. But the one thing that we made very specific, that they cannot sign away the rights for the film not to be allowed in a court of law under court procedures. They cannot sign that away or say the person who wants the camera, you cannot use that film in a court of law if you think there is if there's a problem. So, really in conclusion, it's a compromise bill. I've worked with the nursing homes. I've stood up to them on things that I didn't agree with, and it is not what they wanted. I can tell you that. Today, coming to me very late are the trial lawyers. Now, they have been very nice working with the nursing homes right now. And, we have made a commitment to continue to work out a few things with them. But we may not be able to work out everything, but I'm willing to work with them on that. So the bill is really a compromise. The only thing apparently we're having a little trouble with the trial lawyers is that they would like, if the roommate objects to the camera, that the roommate be moved. Instead, we have put it on the person that's wanting the camera. If you want a camera in your room and your roommate objects to it, that you can be asked to move to another room if one becomes available. And if it's private, you have to pay for it. And we made accommodation for while you're waiting for that, not turning on the audio and only having a camera directed directly at you. And we think that responsible lies with the person who wants the camera to move, not the person's roommate who's objecting. And also, there are CMS rules that say the patient, that the roommate shouldn't be moved. And anytime you start moving elderly people with cognitive disorders that are settled into a room, this is not good for them. So really, it should be the family's responsibility or the patient's responsibility that wants the video to move if that's the only option that they can have on that. So really what we've done, it's a compromise bill that provides easy to follow processes for families to openly place an electronic monitoring device in a room of a family member in an elderly care facility. It addresses and protects the rights of residents and roommates, addressing mental competency and privacy rights. It addresses several practical matters like cost and installation, and it addresses the use of the recordings obtained, but does not alter or restrict the admissibility of the recordings in a court of law. I think we've struck the right balance, and I would appreciate, I'll answer any questions, and I would appreciate a favorable vote from the committee if they so desire.
Thank you, Chairman Cooper. I want to mention first that a couple of things that you mentioned. I agree with you wholeheartedly, having done provided residential services for many, many years. I would think that to force a resident of a semi-private room to move because they don't want a camera in their room would be inappropriate, and more especially in light of the fact that many have cognitive issues, and where they're accustomed to matters. And when we change that, we really impact their lives. Furthermore, the issue you mentioned with the ombudsman, like yourself, I have tremendous respect for our long-term care ombudsman and all of our ombudsmen across the state. And but I do believe that the family and the resident, when they are admitted, when they establish policies for when that camera should be on and off, I think that we want to make sure that we honor that, because as people deteriorate and become, more and more demented, they may fail to do so in contradiction to really what their wishes were at first. And so I think that you are absolutely correct with the version, the LC number that you brought to us today to address that issue. Okay, we have Chair Lady Cooper. We have several questions here. We'll begin with Representative Donahue.
Chair Lady Cooper, I have one main question. Have you been hanging out with Chairman Allen Powell a lot lately?
No, sir.
Okay, some of the remarks, I was just curious, but thank you very much.
Ooh, okay. I will take that as positive. Thank you.
All right, Representative Byrd, is it Representative Byrd? Is your light? Yep.
Yes, sir. Thank you very much. Thank you. I apologize for not being here for your first hearing. So am I to understand that you are this will be a mandate on nursing facilities to put cameras in?
No.
Okay.
No, in fact, that suggestion came from Representative Lahood, who thought that there might be facilities that wanted to have that as another amenity. And so we put it in as a possible option, but there is no mandate. If a person wants a camera in the room, it is the person's responsibility, or the family, if they are making that decision, to let the facility know and to buy the part, be responsible for the installation, be responsible for any damage done to the installation, pay for Wi-Fi if the facility doesn't. The only thing is that they really couldn't be charged for electricity if it took a little bit of electricity, but all the other expenses are the responsibility of the family or the patient.
And do nursing facilities now have Wi-Fi? I mean, I have not been in a nursing
Well,
facility, so I
Representative
don't know.
Lahood, could you please answer that for me?
So there's no standard that all nursing facilities or long-term care, you have Wi-Fi. Some do provide Wi-Fi to their residents and some may not. In the case of these electronic monitoring devices, if a lot of high volume of residents decided to do this, it would pull pretty drastically on the bandwidth. And so the provider would need to subscribe to more bandwidth.
And charge
so-
a small,
and
reasonable
charge a
fee.
fee to cover that. But my thought was that some providers may decide, to really embrace the concept here and make it easy for residents and families to have electronic monitoring in their room. Go ahead and set up equip the space with the equipment and the data and everything to make it easy for them. And I believe, in my experience, I think some residents and families would be more than happy to pay for that service if it was made convenient to them.
I mean, that would certainly, being totally, I hate to say it, but ignorant of, this kind of recording device or how to put it in or what you do with it or what would be the best thing. If that kind of thing, service was offered to me and I had an elderly parent, I would take advantage of it. But it does not require that even if the facility has that, it does not keep you from putting your own in if you want to turn down the services that they have.
Yes, ma'am.
We're moving towards cameras everywhere in hospitals, et cetera, so that people have the ability to see their patients.
Well, considering the fact, like I said last time, that when my sweet corgi was alive, she'd go to daycare and I could, on my telephone at any time during the day, pull up and watch what my corgi was doing in the daycare facility. If people are that concerned over their animals, I hope we reach the point where they are concerned over the care of their senior loved ones. Because, we have too much abandonment and neglect when seniors are put in facilities as far as families, thinking that everything is hunky-dory and they don't have to check on them and that they're, totally being taken care of. So I would like to see us reach that level of caring and concern and observation of our senior loved ones.
Thank you, Representative Byrd. And just want to remind you, in the measure, the family and the patient is responsible for whatever they have to do to access the Wi-Fi, whether it's available in the facility or not. That is the responsibility of the family. Is that not correct, Chair Lady Cooper?
Yes, sir.
Okay, Representative Kirby.
Thank you, Mr. Chairman, and thank you, Chairman Cooper. I appreciate the bill. I'm in support of what you're doing here. I do have a question though, and I know a lot of this committee and other committees have noticed in the last 10 months, I've lived on Zoom, Skype, and Microsoft Teams. It's a great thing. If I read through your definition on line 22 through 25, if the resident has a laptop with a camera built in, would they have to go through all the agreements on the back, especially with the roommate, to do a Zoom meeting that, with a family member or loved one?
I'm going to have to add, I don't believe so, unless they were recording it on the Zoom for.
Which can be done. So I could record a Zoom meeting from my office if I needed to.
Can I ask the lawyer?
Yeah, that might be.
This is a technical question.
Yeah, Georgia Healthcare Association is here, and we definitely want to hear from them later. But if y'all could help us at this point, Josh. Sure. Thank you.
Thank you, Mr. Chairman. It's a good question. I'm Josh Bellenfano with the Robbins Firm representing Georgia Healthcare Association. It's a good question. And frankly, if you ask two lawyers, you'd probably get 7 different answers on it. I think it's one of those things that can get flushed out, but I do think this bill sponsor is correct in terms of the recording device. And so if you had a Zoom meeting that's being recorded, arguably it could fall within that. If it's just a live streaming, I don't think that would be an issue. But
okay.
Thank you, sir. Very good question. All right. Any other questions from the committee for Chairman Cooper. Oh, I forgot. I'm sorry. Hold on one second. Representative McLeod, I got to get Representative Bazemore first. For some reason, the lights don't always come on. Representative Bazemore, this should be your number.
Thank you, Mr. Chair. Thank you, Madam Chair, for bringing this bill. Just had a question. I heard you mention that you were working something out with the trial lawyers.
They had a couple, I mean, they're really wording issues, and Josh has made a commitment to work with them as we go forward, because they did come in late. I mean, today was the first time that anybody had talked to me about it from the trial lawyers. I understand they're pretty busy on the other side and apparently didn't get over to me until this morning. So we've made a commitment, and Josh and they said that they're working very well together.
Okay, so there
on
might be
issues.
changes down the
Right.
road.
The only thing that would be a problem would be the one we're asking the roommate to be moved, because really, that is in the regs on about that, and CMS frowns on that with great frowning.
Thank you, Madam Chair.
Thank you, Representative Bazemore. Representative McLeod has a question.
Yes, Chairman Cooper, and thank you, Chairman. Overall, I think this bill is really good. I think it's going to be impactful for our state and the people that live in here. So, and for those who really want, like you said, if we can do it for an animal, we can do it for the human animal.
That's right.
What I would want to ask was, you have a lot that turns off the camera. Who is responsible for turning on the camera once you turn it off?
Well, if the patient was able to turn the camera off and on, it would certainly be the patient's right to turn it off and on. If it's not, it will, if the patient can't, what tend to do when you have care plans for patients, in order to know what the patient wanted, what they tell me is that there will be some kind of a little notice thing, care plan thing on it, says the patient wants the camera off, that would be, visible in their room when they take a bath or when their physician is, and that would fall to the nursing homes to do it.
Could we put something in this just to be clear? Because I don't want it to be turned off and then becomes ineffective, right?
Well, what would happen is if, the lawyers tell me, and you can verify this one, okay, if it wasn't turned back on, okay, what they would look at is whether that was habitual. It got turned off and it was off for 5 hours, or every time that somebody comes in and the bathing routine, it's not turned back on. And then that would be a red flag to that, but it would be up to the facility.
The facility.
Right.
Okay.
If the patient can turn the camera off and on, and I imagine in many of the assisted living facilities, the patients would be able to turn it off or on, and it would fall on them if they don't turn it back on. But in a nursing home with the cognitive problems they have, and even in assisted living facilities, when we thought we started assisted living facilities, we thought people in their late 60s would be the patient population. And that is not so. The average age is 84. So even in the assisted living facilities, patients are beginning to have cognitive problems. Once you hit 85, 1 out of every 2 patients has a beginning form of dementia.
I want to make sure that the purpose it was put in there in the first place, that it actually works for those patients that are going through those things. And that's the reason the family wants it.
Right. And families have responsibility too. I mean, if they're putting a camera on to look after their loved one, they have a responsibility to look at the tapes. And if there is a pattern of turning it off, or if it's turned off, a call to the facility. Why is mom's camera off? It's been off for 4 hours now. Can you go turn it back on and tell people to keep the camera on? There are, here again, responsibilities on both sides, but what they look for will be if there is a pattern about it getting turned off and not being turned back on.
Representative McDonald.
Point of clarification on line 122, a person is prohibited from knowingly hampering, obstructing, tampering. All right, if the family says they want it left on permanently and it gets turned off, what is the punishment for the person that keeps turning it off? What what recourse does the family have to talk, with the institution? I mean,
There are departmental regulations about punishments. Josh, do you remember? We've discussed this so many times. I'm sorry,
I just want
Representative.
some clarification,
But
just like
there
the representative saying about the turning it off. But if this person keeps continually doing it, what?
Well, if there's indication that there's some reason they're turning it off because they want to mistreat the patient or some kind of foul play, that certainly would be a criminal offense. But I understand. Go ahead and let Josh ask you that there are rules from the department.
Josh, would you like to speak to that?
Sure, happy to. Another good question. And part of it is it's a new day, so to speak. So there's once the obligation is imposed on them to do it, I think the department, and there may be some disagreement about this, but the executive branch would likely have the authority to go in and follow up on that. If they don't, there are plenty of folks in the private sector who, if there's harm that arises out of it and they found that somebody turned it off, that would be a significant problem for that facility. I don't know if that answered your question, but I think that's what. And I'll be candid in working with Madam Chair. We have tried to come up with situations to add some kind of punishment to it, and frankly, did not want to criminalize behavior that was happening in a facility, either for the family or for those that are operating the facility. If you were to do some kind of civil fine from the department could only reach those that it has jurisdiction over, and it may not reach, those outside of the facility. So it's a difficult question. And I think we just left it to allowing the departments under existing authority to try to do something.
And, as we've seen with other bills on the elderly, there is no perfect bill. And as we make these laws and go forward, if changes need to be made, and it's not working, I'll be back to make the kind of changes. But I'm pretty sure right.
I'll be back. All right. All right.
Because I had to work with lawyers on this, and I'm not a lawyer,
Representative Lahood has a question, Chair Lady.
Okay.
We'll go to Representative
Mine's
Lahood.
more of a statement, and I just wanted to say, for 3 years in a row, this bill has come up and we've debated it exhaustively. This is the best version I've seen in 3 years, and like it's already been said, it's hard to get these things perfect. And I believe if the consumer gets a lot of what they want, but maybe not everything, and the provider and the compliance, folks get a lot of what they want, but not quite everything, I think that's a pretty good outcome and a good step forward. This is a big advancement, for Georgia to be doing this, and gets us a long way towards modernizing, policy in long-term care. So I just want to go on record and say that.
Representative Hood, I will tell you, the facilities didn't get much in this bill. The patients got a lot, because as I kept telling them as we debated this, I'm a patient advocate. I'm not working for you, and that's all I care about is the patients. And so it protects their privacy, makes it loud and clear that they can have a camera in the room and the families can look after and see what's happening to their loved ones. So I think that the facilities got a little bit like on not having their walls torn up or not having to pay for the installations and so forth, but basically the patients got a lot out of this.
Okay. We're going to try to get down to all these questions because we do have some other testimony from the Georgia Healthcare Association. Representative Jaspers. Oh, I'm sorry. I'm sorry, Representative Robichaux, forgive me.
I think I agree with you. And I think as we catch up to this as we're catching up to this technology, I think people or the consumers and the families will learn to put it in the care plans of when it gets turned on and off. If I've signed, especially these agreements, and that's, as you know, in healthcare, that's how we can start to hold people accountable. If it's in the care plan and you're not doing it, I think that's where it's going to come down.
And thank you, Representative. That's why we made and put into the law a form which says what they check off and what they want. And that would be put in their permanent file and put into a care plan.
Yeah, in their care plan. That's what you can hold them accountable to.
All right, one quick question, then we're going to go to Representative McDonald.
Point of clarification, you said you're a patient care advocate and you're an advocate for the family. Is that correct? For
If they're looking out for the best for the patient, I am.
But both the patient and the family.
Yes.
Okay. I just want to make sure I've understood that correctly.
Oh, no. I mean, I'm a master level nurse by profession. My husband was a physician. Our whole adult life has been spent in promoting good health care for patients.
All right, we've got all of our questions have been answered by the members. I believe we have some testimony by the Georgia Healthcare. Oh, I'm sorry.
Mr. Chairman,
Madam Chair.
At the proper time, Will Johnson with the Prosecuting Attorneys Council brought up something that needed to be deleted, and I'll make that amendment. It's a friendly amendment. It's on page 2.
Okay.
It's line 222. And the reason for it has nothing basically to do with this bill. It might interfere, as he tells me, and he can testify, with something you can do at your houses. Nothing to do with elderly, but on the surveillance at your homes or something, that they wanted it taken out. So I just thought I would tell
Okay.
you that ahead of time.
All right, so we will anticipate that.
Yes, sir.
Chair Lady, if you could write out the language we'll need.
Oh, just a
that-
minute.
That might be helpful. Okay, Georgia Healthcare Association, and by the way, are there anyone else? Is there anyone else that is here that wants to speak to this measure? Okay, all right, then you're next, sir. Okay, Georgia Healthcare Association.
Thank you, Mr. Chairman. Thank you to the members of the committee. I will be brief, recognizing the hour. I think the chair and sponsor has said it well. We did work hard on this bill with Madam Chair. She beat us up pretty bad. But I think we ended up with a very good compromise bill, and I'm proud to hear that it being described as the best version that's been done. I know I've worked with Representative Douglas on many things in the past as well, and he's co-sponsoring this bill and supportive of it. And so thank you for this. We will continue to work. When we heard from the trial lawyers, I've been working with them over the weekend. We've been working in good faith. And I think, like I said before, whenever you get 2 lawyers to look at something, you're going to get 6 different answers. We may move a comma, we may add a word or two, but hopefully much of the substance will remain the same. Thank you.
Are there any questions from the members? Okay, all right. And I'm sorry, I do not have a sign-up sheet if it's here, sir. Is this Georgia Trial Lawyers Association?
Yes, sir. My name's
Okay.
Mike. My name's Mike Prieto, and
Thank you, Mike, for being here.
Yes, sir. By way of brief introduction, I want to tell you that I am a 31-year and serving Army officer. I live in Brookhaven with my wife of 25 years, and I am an attorney, and I have focused my practice in long-term care litigation. And I bring somewhat of a unique perspective to that realm in that I worked my way through college as a CNA. And I will tell you that there are many wonderful providers and very special people who work in long-term care in this state. Now, this bill is coming to you today as a result of what happened at a facility here in Atlanta. I represented Mr. James Dempsey. Mr. Dempsey was a 37-year Army veteran who was at a skilled nursing facility, and he lived into his 90s at home, had a slip and fall while he was cooking biscuits in his kitchen. So he had to have hip surgery. He went to a facility to rehab. But like most residents at a skilled nursing facility, he had numerous other comorbid conditions. And Mr. Dempsey had a respiratory issue. Now, many of his items came up missing. The family was concerned. And so they put in a camera to check on their father to see what was going on. And they left it running. Family came in every couple of days, switched out the memory card, and kept it running. They received a phone call one day and said, "Your father passed." Now, if you look at the clinical record, what was actually charted by the healthcare providers, he simply passed in his sleep. However, when they went back and watched the video, there were 6, 7 instances of Mr. Dempsey screaming for help. "Help me, can't breathe. Help me, help me." And the nurses did nothing. They said, "Stop using your call light. There's nothing wrong with you." He passed right there on video. I watched it. It's heart-wrenching. And then 45 minutes later, right before the EMTs show up, They walk over and start doing CPR on Mr. Dempsey. They tell the EMTs, they say, oh, we don't know what happened. He just stopped breathing. And it was the video that brought this to light. And so thank you, Madam Chairwoman, for bringing this bill, because it is important legislation. The existing law in the state of Georgia today is that you do not have the right to videotape individuals without their consent unless you're in a public place. Period. That's the law. And what the Knuckles decision did that just came before the Supreme Court, which was the impetus for this bill, it recognized the fact that Mr. Dempsey was in his home. You know, you hear a lot of people talk about patients, and with all due respect to everyone, I will tell you there are no patients in a long-term care setting. It is their residents. They have a right to vote with that address. They have a right to get government-issued ID from that address. They have a right to probate their estate in the county in which that address lies. It is their home is as much as you go home to your home and it's their home. And the Knuckles decision said, because it was your home and you were concerned about your safety, that you met an exception and that you could record. That's what the decision said, and that's the current law in the state of Georgia. Now, what this legislation would do is broaden that, which is a wonderful thing. But respectfully, I think the devil's in the details. And I understand that people are saying that we're late to the game. I spent all weekend reviewing this weekend, and I do think there are issues that are left unresolved. There are a lot of practical application in a skilled nursing setting that I think leaves a lot to be discussed. For example, if you turn off the camera, right? What happens? You know, and if you have a slip and fall at Walmart or Kmart and they destroy the evidence, there's a spoliation charge that's given to a jury that creates an inference. And so we think that there should be some type of teeth in this. We look at our HIPAA bills, our HIPAA laws. If you violate HIPAA, what does it matter? Really nothing, because there's no teeth to the law. And there needs to be some kind of teeth here to mandate that it's enforced, because the goal is to protect the resident and that resident's rights. The second that I respectfully disagree with is the thought that one must have permission of a guest in their home before they're videoed. Now, these cameras, and I think there's a misconception, these cameras are not cameras that are up in corners that have the entire room. Like Mr. Dempsey's camera was a camera on his bed in his living space. And that is as much a resident's living space as you going home to your bedroom. And if you go to your home and you decide that you want to have a camera running at your home, are you really going to ask any visitors into your home, stop this camera, let me get written consent from you to do it? The Bill of Rights under the OBRA regs, under the Georgia Bill of Rights, says that that's his home, it's their home. And if they choose to video within the confines of their home, on them, not on the roommate, on them, they should have every right to do so respectfully. It also, another issue that I would like to point out is that I don't think it really addresses who can grant permission from the resident. Right now, if you've got a roommate and you've got a roommate's family who's been there for 6, 8, or the roommate's been there 6, 8, 10 years, well, how are you going to get their contact information? Who's their responsible party? Does the facility have an obligation to give that personal information from one resident to the roommate? I just feel like there must be a mechanism by which they can obtain the proper party to issue that permission. And I think that the bill really doesn't address that. I think these are things that can be worked through, but respectfully, I just think that those are issues that are outstanding. The last thing that I would like to bring up is we talk about the resident's agent, and there's a quote back to OCGA 3192. And it says that anyone within the first 5 paragraphs has authority to execute. However, I do find it a little bit odd that someone with, if you look at the entire body of that statute, it lists other people, and those people have the authority to go in and contract for admission to a long-term care facility, but yet they would be precluded from granting consent on behalf of their resident to actually execute permission. So again, I think this is wonderful legislation. I applaud the effort. I just hope that we will take a little bit more time to consider some of these issues and the way that it will be practically applied in a skilled nursing setting. One last thing, there was a requirement that in order for a family member to authorize the use of the recording device for their loved one, that there must be a physician's assessment to make a determination of lack of cognition. But under the OBRA regs, a doctor doesn't even have to see someone until 30 days after admission. 30 days. Now, how many people are going to know when they're leaving an acute care setting or a hospital to say, oh, by the way, I need to address this? They don't even know to think about it. And so then they're precluded for 1 month at least before there's a determination. So I just think these are some practical things that we need to work through. And I thank you so much for your time. And I'll be happy to answer any questions.
Thank you, Mr. Prieto. Let me mention one thing. Do you represent the Trial Lawyers Association,
I do.
sir?
Yes,
Okay,
sir.
thank
Yes,
you.
sir, I
I
do.
think everyone needs to know that. And I had a question. So one of the things you raised as it related to teeth and enforcement, and I just, I'm asking a question. It seems to me that the department would promulgate rules once this is established, like all the other statutes around these different types of facilities. The department would then establish rules for what penalties and provisions are for violating those rules. Is that correct? And,
Well-
and to anyone that's in the room, I'm
Sure,
asking that
sure, it
question.
could be correct, but look at the responsibility of the big issue is the spoliation, right? If there's evidence out there of an adverse incident, everyone wants to know it, because in fact, that's why we want this, is to record any adverse incidents, right? As a family member. So the bill in its current status puts an obligation on the family member. How long do they have to keep video? Well, we're putting a burden on the residents' family members that won't exist in any other context, because if they were, well, think about it this way, Mr. Chairman, if there's an adverse incident, then the facility has a right to say, hey, give that to us, which is very appropriate. Let us see what happened. But what is the family member's obligation to keep and store that? Do they have to have a device that records over 20 days, over 30 days? Is it something that's backed up to the cloud? And if it erases, does that create a spoliation issue for them? And so I just think there are unanswered questions. I hope that answers it.
Thank you, sir. Any other questions from the committee for Mr. Prieto?
Thank you
Am
for
I
your time.
pronouncing that correctly, sir? I want to make
Yes, sir.
sure.
No, it's perfect.
Okay, thank you, sir.
Thank you.
Is there anyone else who would like to speak to the bill? Any guest here that would like to speak to the bill? Okay, there being none. Chair Lady Cooper, I think you wanted to make a recommendation that
I
that we
did.
might consider as an amendment.
I did. And is it all right if Mr. Belafonte responds to some of the things? I have a sister that's a lawyer, used to practice in a small town and often was a trial lawyer.
Mhm.
I didn't always like her when she did that. But I do appreciate
But-
what they've brought, but there's a lot of what ifs.
But yes, we'd be
And-
glad for, you want Mr.
Right, and I
Belafonte
do.
to speak.
And all
yeah,
I'm going to
answer
say
questions.
is
We can, yeah,
that,
we can
right,
do
that we have made a commitment to continue working, but I'll let Josh answer and respond to
And,
this.
and Chair Lady, if you have that language, do you want to provide the language
do.
to Betsy, and then we'll have it precise? Thank you, sir.
Thank you. I will continue to try to be brief. The bottom line is this. I mean, a lot of these issues we started learning about over the weekend we've worked to try to get some language, but rather than get something quick that is going to get amended down the line, we've talked more about policy and how do we get an agreement on policy and then start to focus on the language. Some of this I think is addressed in the bill already, some of the things you heard, but one of the key things is, and as you vote, think of it this way too, it's not just the roommate or it's not just the resident that's on that camera. You've got audio perhaps, and you've got audio that can pick up the roommate, and that roommate could be having discussions with their doctor, with their pastor, with their spouse, with their lawyer. And so we've got to balance both of those issues, which can get complicated, particularly if you're trying to write it out as precisely as possible in a statute. So our commitment on behalf of GHCA is that we'll continue to work with folks to address these issues. We've already, I think, come to an agreement on some potential language, and we're getting closer in terms of substance. So unless there's questions about it, I would end it there and ask for your favorable vote, and thank you.
Yes, sir. We do have a question. Representative Lahood, I believe, has a question for you, sir.
Well, it's might be more of a statement, but so listening to the testimony from you and the previous presenter, in my experience, I operate long-term care communities, assisted living to be exact, and the people that work in our buildings, they work there because they care. You know, if they didn't, they wouldn't stay in that job long. And there's a lot of situations where the procedures for turning the cameras on in this situation, off in this situation, on again, off again. There are a lot of situations that just happen in the spur of the moment, and the caregiver may be darting on one side of the room, darting back to the other side of the room in the best interest of that person they're caring for. They might, be running to prevent a fall from happening, or running to go get some supplies and come right back to the bedside. And the very thing that the intention of the cameras is to help to raise the bar and ensure quality. So a couple things here. One, I've had experience with families who installed cameras because they thought maybe things weren't going exactly as they should, and they were proved. Their confidence increased. Their confidence of the facility staff to provide good quality care increased when the camera was put in the room. They saw, oh, mom is being checked on a regular basis. And the other thing is, the very thing we're trying to accomplish here, if we get too technical and put too much undue obligation on the staff of the provider, we could turn the table and it could be counterproductive. If so much pressure is put on them on when to turn the camera on and off, they could get more focused on that than they are on actually providing the care that's needed right then and there at the moment in real time. And so that's one of the practical things that's hard to understand unless you've lived the life of a caregiver and been in these environments, day in and day out.
Representative Kirby.
Thank you, Mr. Chairman. We heard earlier in the testimony, and you look on line, starting on line 131, talks about the possession of the materials that you've recorded. And we've used the word reasonable here several times all night here. Does it seem reasonable that a family member that would be threatening a lawsuit would do away with that material at all? I mean, whether they don't have a reason to keep it for 20 years, but if I've got a problem with the way they're taking care of mama in that facility, I'm going to hang on to that video.
That's right. And part of the concern, and actually to Representative LaHood's thing, is what about the flip side? What if there's an allegation made and the facility knows because there'll be signage and everything else that there's a camera in there, but suddenly the family doesn't want to show you the video because it does show that there's been high quality and good care. And the facility ought to be able to, as the family would, if the facility destroyed the tape, raise that. And I think that's the reason that would be in there. It's for the flip side of the analysis or the situation you've articulated.
Okay. If there are no questions, no further questions, it appears we're none online, Tara. Okay, we are going to ask Chair Lady Cooper to explain to us as we continue to discuss this issue, a recommendation for someone may choose to make as an amendment. Chair Lady Cooper?
Thank you, Mr. Chairman. After a consultation with Betsy, our learned attorney, I think that we have to, I will rescind the desire to make
Okay.
an adjustment on that. And I have one more thing I'd like to say. I truly believe, like Representative Lahood, that having cameras out in the open will help increase the quality of care for our seniors. And it also protects the workers there too. When a senior is older, very often their skin will break down, or even touching them will cause bruises. So let's say that mama gets moved up in bed, and I come in later and find that both her arms and wrists are all bruised. I could think that that was abuse. But if I have the camera and I can watch the caretakers, one on each side of the bed, you know, hold mama in the right way and lift her up together on the bed, then that shows that they were doing what they were supposed to do. I mean, we have a hard time getting people to work in our assisted living facilities and nursing home. It's hard work at low pay, at lower pay than many jobs. And many of them are dedicated. And I would say that's, you know, probably 90-something% of them. There are other incidences that are not good, like the one the trial lawyer said. That's horrible. And I'm so glad that there are people like him to take that kind of case. But we have to find a balance here between what is best for the patient, allowing these facilities to still be able to get staff and continue to take care of our seniors, but also that not setting up set just for lawsuits one right after the other, but when there is a need to go the civil route, that there is also that possibility. And we have tried really hard to do it, and we'll continue to work on that. And before my phone died, because we're here late, and thank you again for staying, I got the message that as far as punishments, there is already in the code and part of our law, and I can't remember which part of the law it is, for the department to put penalties on. And like, you know, if there's a consistent not turning off or something happens, it's in the code already with the department. I'm sorry. And tomorrow, when my phone works, I can give that to you, Representative.
Thank you so much.
Thank you very much.
Oh, yeah. All right. Well, I think we've thoroughly discussed this measure in now 2 different committee meetings. I see no further questions. What is the will of the committee? We've got a motion. We've got a second. Any discussion on substitute to House Bill 605? Any further discussion? We have a motion and a second. Okay, Representative Bazemore, again, your light's not coming on. Forgive me.
I hear it.
Bazemore.
Okay. I just wanted to say, I like the bill, but I'm concerned about all of the questions that were brought up. So if it's worked on, then I can vote yes, but right now I don't think I can.
I think that people on in this committee know that I'm a person of my word. We are getting close to crossover. Our time is running out. I have made a commitment. The nursing home people have made a commitment to work on this. We may not agree with everything that the trial lawyers want. Like I say, I'm not in this to make it give the advantage to the trial lawyers to sue people, or to make it easier for them to sue when there maybe might not be a reason, or to help the nursing homes. I'm here for the patients, and I have made a commitment that I would work with them, and my word is my bond, and I will do that going forward since we are getting close to crossover. So I would hope that everybody would be able to vote in a positive manner for this bill.
Any further discussion? Any further discussion? Any of the members? Any online? No? All right, there being no further discussion, we've got a motion and a second. All in favor of passing the substitute to House Bill 605, vote aye.
Aye.
All opposed?
No.
Okay, let's just make sure Tara has got our eyes and nose. You good? Okay, the measure passes. Congratulations, Chair Lady Cooper. And this meeting is adjourned.
Thank you to the members of the committee. Thank you.